A lot of success stories this afternoon, and I'm wondering if there is a particular success story between critical care and supply chain management that you'd like to share with the group here. If there's anything in particular that stands out, why it was a success, and then I'm going to flip it and ask about a particular challenge that you've faced with supply chain management, whether that challenge has been resolved, and if it hasn't, what's happening to date? So who wants to tackle that one first?
I can speak from a global perspective. Again, I don't work on individual projects very often in my line of work. Most of what I do is working with the process. I'll give you an example though. We had, most of the time when things go really bad, it's because one of three things. Either the stakeholders weren't identified and involved from the beginning, bad communication, or there weren't aligned incentives. And what I mean by that is that one person was being incentivized in one particular way and another. So if we look at physician preference items, for example, the physician is being incentivized to do more procedures and the hospital is trying to reduce the number of products and procedures that are done. So we don't have aligned incentives. So typically those are the three areas that I see. We had an occasion where we were working with one of our members on a large savings on a West Coast hospital for looking at their use of a prepackaged bathing product. And it was being used throughout the hospital. And granted, these products do have some great merit, and there are definitely applications where they should be used, but using them throughout the hospital is, in my opinion, overboard. And so they started to work on the project, and they were going to eliminate it and go back to the way that they were doing things before they brought this product in. They were down to the wire, and what they had realized is they had not involved one of the stakeholders who was instrumental in bringing that product into the facility, and in this case it was a CNS from the ICU. And so this person, really started to kind of go back channels to keep this product in-house. To make a long story short, they were able to come to a compromise, and indeed the product was left in the ICU to be used on all ICU patients. So that's just one example of, it really started to go bad, and the reason was there was a key stakeholder who was not identified and involved from the beginning, and a lack of understanding on both sides as to why this product was brought in, what the history of it was, and what's the appropriate use for the product. So I think that, again, if it's a project that's gone bad, it's either communication, stakeholder involvement, or aligned incentives.
And I have to add to the story, because in our health system, the bath product, they were allowing it only in our critical care areas, and as a cost savings on the inpatient units, you imagine the cost savings across the 17 hospital system. They went to disposable washcloths. Well, all the hospitals start having significant plumbing problems. And recently, a number of the hospitals have gone back and done the cost-benefit analysis of all the plumbing repair expenses that they have had related to this, the damage, water damage to areas that this affected. And they have actually gone back to the disposable bath product for the inpatient areas because of that significant cost that was incurred. And as much as you train nurses or educated them, how to properly dispose of these, I think there is still this mindset of nursing when you're using that type of product. I don't want to throw it in the garbage can. It needs to go in the toilet. And so I think sometimes when you talk about something that you think is going to be a very significant cost savings, and it came back and it affected a department probably nobody thought, our maintenance. So I think that, sometimes you have to go back to the drawing board for sure.
In our process, we call that measurement and sustaining the program. And yes, what you say is very true. Oftentimes there are results a change that you made that you didn't anticipate. I'll give you an example. We had a member who the value analysis team made a change in the facial tissue that it was using, and they went to a lesser quality facial tissue. Well, the chaplain staff, this took some time to figure out what had happened, but what had happened was the chaplain staff were unhappy with the quality of the facial tissue and didn't feel it was performing the standards for their grieving patient families, and so they opened sterile 4x4s to give to the grieving families to use as facial tissue. So, the savings, the 2 or 3 cent savings that they thought they were going to receive on the one side was well overdone on the other side with the addition of opening up the sterile 4x4. So it's really important when you're looking at making a change that you do that measurement on the back end. You should anticipate your usage of a product, and if it is below what you anticipated, then that should be a trigger red flag for you to say, what are they using instead? Because I'm telling you, I'm a nurse, and we are great at finding workarounds. So, what are we using instead of this product that they were supposed to use? And then the other side of the equation is, if they're using a lot more than you anticipated, what are they using it for that they shouldn't be using it for? For instance, if your butterfly needles is 98% of your utilization in phlebotomy, that's not good. You really should shoot for 20% or less. Yes, there's a certain patient population that should have butterfly needles used on them for phlebotomy, but the majority of your patients, or the patients in the hospital, should be receiving a straight needle for that purpose. So both sides of the equation, you have to make sure that you're looking at the back end to see, did you get the results that you were anticipating? And if you bring a product into your ICU because it's going to do X, then making sure that you follow up to see, did it indeed do X? Because if you're paying $10 more per product for something, and then you're not seeing any results on the other side, you're just throwing your money, $10 per time, out the window. For example, I worked with an organization who was using vascular sealing devices so that they can move their patients out of the cath lab quicker. With a vascular sealing device, there are other benefits, but one of the main benefits is that you can discharge the patients in 2 hours post-cath. Well, they never changed their protocol, their guidelines, so their patients were still being held for 6 hours. So now we're paying an additional $225 per patient, and we haven't reaped any of the benefits that we anticipated we would reap going into the project. So I just encourage you that anytime you're involved, that you always look at it on the back end. And if there's one thing I see that people miss, organizations as a whole across the country, it's taking that look back, because we check something off, we finished with that project, we've got 10 more on our plates, and we never go back and look at that project to see if it really accomplished what we intended for it to accomplish.
I think we all have many examples of those kind of things, but I was thinking primarily of in our product evaluation analysis committee. Several months ago, we looked at changing our gloves, and decided that the product that we were looking for, probably preferred, was a little too costly, so we didn't make the change. A year later, we go back, look at full usage volumes again, and are finding that a large number of departments are going ahead and ordering them, using the backdoor route. So, any things that we thought that we had, accomplished, we did not see. So again, yes, just take a look back, keep evaluating and reevaluating.
And one thing I want to add too, when supply chain does make changes, when we went to our standardization conversion, like for our ER, for some of the mobile products, I would call it, they brought in a company to help supply them, and then it's charged back to the patient, through a billing process. And one of the things, then if it's not a routine stock item, the unit has to then do an individual purchase. But then what's happened in my emergency room is they're having to put orders in through our ordering system for an amount that would be beyond anything that they would ever use in a reasonable amount of time. And I think it was a scrotal support what they would have to order they would never even use in probably a year's time. And so we had to be creative and say, how can we share this with another hospital? If I ordered this time, you ordered the next time, or even for our smaller hospital, we have a small hospital that is connected with our community hospital. It's only 33 beds, but they do 26,000 ER visits, of which 25% of those are pediatrics. And so ordering the little Pedialyte popsicles, we've had to share that.